Tracheostomy care and sectioning for pediatric patients. Objectives. By the end of this PowerPoint presentation, nurses or nursing students will state when it is clinically indicated to section a patient with a tracheostomy. Nursing students will demonstrate how to section a patient with a tracheostomy. Nurses or nursing students will state when it is clinically indicated to clean a tracheostomy. And finally, nurses or nursing students will teach back the steps of cleaning a tracheostomy. What makes up a tracheostomy? First, there's the connector, which is the part of the tracheostomy tube that sticks out of the neck that can connect to the ventilator in the ambu bag. The outer cannula is the part of the tracheostomy tube that goes inside the windpipe or trachea. The cuff is a small balloon filled with air that helps to hold the tracheostomy in place and prevent air from escaping around it. The side port allows the balloon to be filled or emptied, and not all trachs have to have a cuff. The faceplate is the part of the tracheostomy tubes where the ties are attached. This is also called the wings of the tube. The obturator is placed inside of the tube to guide the tube into the trachea during insertion. It is removed after the cannula is in place. Inner cannula. A replaceable cannula that fits inside the outer cannula and can be cleaned and replaced, used on larger tracheostomies. Types of tracheostomies. On top, you have the Bavana cuff trach. The cuff trach has a balloon that is inflated once it is inserted into the neck, and this helps keep the tracheostomy in place. At the bottom is a shyly uncuffed tracheostomy. Different trachs for different kids. As you can see by these three pictures, trachs don't always look the same in all your patients, and it is good to get used to the type of trach that your patients have as well as the accessories that they need. In the first picture, the child just has the normal tracheostomy and there's no accessories, where in the middle, the child is using a ventilator to help him breathe. And on the end, they have a humidifying device on the end. That way, the mucus and secretions aren't as hard and they are humidified. There are many different reasons where tracheostomies are indicated, and some of them include an airway obstruction or blockage that has occurred. There's excess thick mucus that is hard to remove and needs continuous suctioning throughout the day. Patients' breathing muscles are weak and need artificial airways, or there's a neurological problem. Per Arnold Palmer policy, there are different times on when it is clinically indicated to suction your patient. At least twice daily, so once a shift, once in the morning and once at night, especially after walking, before meals if necessary, after naps if necessary, and before bedtime. And you also need a suction if the patient's condition indicates. Clinical indications to suction a tracheostomy based on your patient's condition include audible gurgling, frequent coughing, visible mucus in the trach, a whistling sound coming from the trach, signs of respiratory distress including grunting, nasal flaring, retractions, and use of accessory muscles, blue lips, mouth, or fingernails, decreased oxygenation saturation, or if your patient requests it. Steps for suctioning a tracheostomy. Step 1. Perform hand hygiene, provide patient privacy, identify the patient, and explain the procedure. First, you're going to connect one end of the connecting tubing to suction machine. You'll turn on the suction. If indicated, you'll hyperoxygenate your patient with 100% oxygen or as prescribed. Using sterile technique, you're going to prepare the disposable suction catheter. First, you'll open the package on a clean surface and use the inside of the wrapping as a sterile field. You'll place the sterile drape on the bedside table. You're not going to want to allow the suction catheter to touch any non-sterile surfaces. You're going to open the sterile basin and fill with normal saline or sterile water. You're going to remove gloves, perform hand hygiene, and don sterile gloves. Next, you're going to connect suction catheter to connecting tubing. With your dominant hand, pick up the suction catheter and wrap it around your hand. This now becomes your sterile hand, and your non-dominant hand will become your dirty hand. With the non-dominant hand, pick up the connecting tubing and connect it to suction. Your dominant hand or sterile hand cannot touch this connecting tubing. Check that the suction is working by suctioning a small amount of sterile solution from the container. With your dominant hand, quickly insert the catheter into the tracheostomy without applying suction. Using your non-dominant hand, cover the control vent to apply continuous suction only while removing the catheter.
So continuing talking about steps for suctioning and tracheostomy, my name is Chelsea and I'm going to be taking over for the rest of the video. If an additional pass is needed due to secretions still in the airway and the patient is tolerating the procedure, we want to wait 20 to 30 seconds in between passes because we don't want to irritate the airway and cause further damage. Hyperoxygenating the patient in between passes for 30 seconds is important because we're going to be suctioning and taking away their oxygen and the air they're breathing, so giving them that extra support is going to help just to prevent any further damage. We want to return their supplemental O2 to baseline, assess the volume, consistency, and color of the airway secretions. We'll be looking for any maybe changes and looking for infection. We want to wrap the catheter around the dominant hand after suctioning is complete. Pull the sterile glove off of the dominant hand inside out with the catheter remaining inside the glove. And we're going to remove gloves and perform hand hygiene. Some important reminders when suctioning a trach is that if accidental extubation occurs, call for help. That's why it's important that we keep an extra obturator at the bedside to insert if the outer cannula gets dislodged, and also an extra trach tube that's the correct type and size for the patient. We're going to manually ventilate the patient with the ambu bag if needed while we're getting help. And to reduce infection, we're going to use sterile technique while suctioning. We're going to limit each suction pass to less than 15 seconds. If the patient is experiencing any type of respiratory distress, cardiac decompensation, or any other complications during the procedure, we're going to immediately withdraw the catheter and provide additional oxygen. So some adverse effects of suctioning include tracheal damage. We can cause our patient to desat and put them in respiratory distress. If our patient's in respiratory distress, you might see nasal flaring, the use of accessory muscles, their skin might look pale and cyanotic, their respiratory rate's going to be increased, they might have some tachycardia, and they might have some wheezing as well. Arnold Palmer's policy for trach care and their indications of when trach care should be done is that when caring for the stoma, the nurse should assess and clean twice a day or once a shift, so day shift, night shift. And then changing the trach ties should be done once a day or once they're visibly soiled. And changing the trach should be done every 1 to 2 weeks as needed and per order. Regular cleaning prevents skin irritation that can lead to infection around the stoma site and reduce the risk for respiratory infections. To perform stoma care, you're going to need a couple of supplies: a clean cotton tip applicator, cleaning solution as prescribed by the doctor, and a split gauze or other dressing. So first, perform hand hygiene. We're going to position the patient on their back. We're going to remove the old split gauze. Assess site for redness, swelling, tenderness, bleeding, or any increased drainage or odor. Wet applicator with cleaning solution. We're going to clean the site starting at the center and moving away from the stoma. Throw away the dirty cotton tip applicator. Use multiple applicators if necessary. And if you're going to be using a dressing, we want to replace it. So when changing the trach ties, you always want to have another nurse or nursing assistant present to help secure the tube while you change the trach ties. So we're going to first position the patient on their back, hold the trach tube in place, and while someone else removes the old ties, whether that being the nurse or the nursing assistant, we want to check the neck area for rash or irritation and clean as needed. Once the old ties are removed, continue to hold the trach tube in place until new ties are secured. Check the tightness of the new trach ties. One adult finger should fit snugly in between the neck and trach tie, and that's how you know it's not too loose or it's not too tight. So now when you're changing the trach tube, you must also have someone with you, and that other person has to be a nurse. You want to gather your supplies, so you're going to need a bag mask, a new same-size trach, a one-size smaller trach for emergencies, new trach ties, split gauze or other dressing, water-based lube, and suction supplies. Position patient on their back and place a small roll under their shoulders. The head should be tilted back, exposing the stoma. So that just gives you a better angle and a good angle to go at when changing the trach. So when changing the trach, the first nurse prepares the new trach by applying lubricant and ensuring obturator placement. The second nurse removes the trach ties from the old trach. When both nurses are ready, the trach is ready to get pulled out. The first nurse will insert the new trach and remove the obturator. Assess air movement through the trach and then check the correct positioning of the trach by assessing the patient. So we're going to be looking at our patient for any signs of respiratory distress, and we're going to be also checking vital signs, their pulse ox, and at the end we're going to attach new trach ties. Even though we're helping our patient, there are some risks that come along with performing trach care. We can accidentally remove the trach when performing trach care. We can introduce infection in our patients, especially if we're not using the proper hand hygiene and using sterile technique. And also, air can get trapped down around the lungs, also known as a pneumothorax, when we're providing trach care. So a tracheostomy emergency would be an obstruction due to a small object or mucus plug. So signs that your patient's trach may be blocked: they may look restless, anxious or frightened, be cyanotic and blue in color, gasping, tachypnic. They may be breathing noisy or may not even breathing at all due to decreased air movement. As the nurse, if you are unable to pass the suction catheter through, that could be a sign that there's an obstruction as well. If you cannot clear it, you want to change that trach as soon as possible to prevent any further respiratory compromise. Another serious tracheostomy emergency would be decannulation, and that's what happens when the trach accidentally gets extubated. We want to call for help. So manually ventilate the patient with an ambu bag if needed, and while you get help. You want to keep an obturator at the bedside to insert if the outer cannula gets dislodged. And for emergency replacement, keep an extra trach tube that's the correct type and size for your patient. And that is it for our video. I hope you guys have a great day, and thank you for listening.